Good afternoon, ladies and gentlemen. A warm welcome back to the APAC HealthTech Innovation Conclave. This is a two-day conclave, and today is a day two. So, since yesterday, we had a plethora of discussion with the key decision makers in healthcare institutions, both from the medical fraternity and from the technology fraternity. In the morning yesterday, we had senior bureaucrats and policymakers uh, talking about the decisions on the policy level, the policy framework on healthcare roadmap for the country and different states being driven and how they are being driven during the inaugural session. We had a few interesting industry sessions where the industry talked about how technology is being leveraged in the healthcare sector. And we had different panel discussions yesterday and even today morning discussing different aspects of how technology is converging with healthcare and sort of helping in improving and catalyzing further digitization of this sector overall. It's my pleasure now to introduce a very esoteric set of panelists for this panel discussion on role of emerging technologies in building smart hospitals of future. So let me introduce the panelists here. We have with us Dr. Venkat Ramana Sudigali. He is the director and CEO of Excel Hospital. Welcome to the discussion, Dr. Venkat.
Thank you.
We have with us Saji Mathew. He is the CEO of Baby Memorial Hospital. Welcome to the discussion, Saji.
Thank you.
We have with us Bhoopendra Solanki. He is the head IT of Sakra World Hospital. Welcome to the discussion, Bhoopendra.
Yeah, thank you.
And we have with us Dr. Radha Krishna Rao Sagi. He is the chief consultant, orthopedic surgeon, and head ORTHOHEXAGON at Prathima Hospitals. Welcome, Dr. Radha Krishna.
Thank you.
Okay. So let's start the panel discussion where we are talking about smart hospitals of the future. Uh, let's what I would want, and my first question will be to Dr. Venkat. What exactly um, are the components, or what do you exactly mean by a smart hospital, especially if we look from three perspectives: the data which is accumulated in a hospital, uh, measuring, analyzing that data to derive insights, and giving accessibility to that information to the patients and the other caregivers. So, looking from this data, insight, and access, these three perspectives, what all is included in a smart hospital? Over to you, Dr. Venkat. So, you are on mute. So you are on mute.
Thank you. Yeah, sorry. Thank you, Mr. Rajneesh. And I thank every organizing member of the APAC panel to invite me for this wonderful meeting and discussion about this important topic, and also privileged to have my colleagues also alongside. It's a very good question, but the answer is quite broad and generalized, and depending on the person you ask, it may vary regarding smart hospital. So there is no defined answer as such regarding what constitutes a smart hospital. What I normally say is there is a spectrum, and how much of smartness, if you may call it, you want to inculcate into your departments or your healthcare organization depends on so many factors, including funding. But probably the most important aspect is the patient's feasibility and the patient's uh, embracing any technology that you use. Because the reason why I'm saying is that no matter how much advanced technology we all can provide to our patients, they're only limited by certain things like the time. First of all, most patients have mobile phones, but are they happy to do teleconsultations in the long run? COVID did take up a lot of space in this, but going back from COVID to normal life, do we really think that this is going to remain in the long run? And maybe a hybrid kind of model can really help us to balance these aspects in the future. Some amount of smart technology, but majority still having a human touch is probably the ideal balance that all healthcare organizations can have. The other important factor is whether the smart hospital using advanced technology, including AI, robotics, etc., will increase, unfortunately, the cost to the patient, cost to the healthcare system in general, and of course, cost to the insurance providers. Because the major point, especially in Indian healthcare system and across many other healthcare systems in the world also, is that any technology should actually decrease the cost to the patient. For example, if you diagnose a cancer patient early in stage 1 or 2, not only the patient benefits with better outcomes, but also the cost that the insurer provides or the patient paying out of his pocket can also significantly differ depending on when you actually diagnose a case. So there are numerous aspects of these very, very general terms and things that I've told, but it's a long topic. It's a very hard topic to really go through the details, but ultimately what I would say is the smart hospitals should benefit patients in multiple ways, in outcomes, in reducing the cost, in improving the patient safety. Thank you.
Thanks, Dr. Venkat. In fact, we would like to talk more in detail about later about this possible hybrid model in future that you are talking about. Next, I'll come to you, Saji. From a hospital's operation perspective, how a hospital is managed and how the operations are taken care of, how different would be for a smart hospital of the future that we are talking about, where these different new generation technologies are integrated? So how different would be managing the operations of such a smart hospital in the future? Saji.
Once again, good afternoon. As Dr. Venkat highlighted, there is no clear-cut definition on a smart hospital. But I would say leveraging technology, especially exponential technology or digital technology that we call, or this IoT of medical things. I mean, the IoT, robotics, AI, virtual reality, augmented reality, leveraging those exponential technologies to provide a better experience for the patients, that's from an operational angle, and also a better outcome from a treatment angle. So leveraging technology, we have used that one, especially during the COVID period, providing a better experience in the sense for a patient coming to hospital for an OP consultation. Now they have a choice of either consulting a doctor or a teleconsultation session, or they can come to the hospital. Even when they come to the hospital itself, we have created systems and processes in place. They don't need to come to a counter. So everything can be done, transacted online. From an operational angle, that reduces my cost, because rather than coming to a staff member, doing a registration, doing a appointment booking. So now I push a lot of things to self-service. So established kiosk throughout the hospital, and also the same services are exposed to multiple channels. So they can interact right from discovering the facilities and the doctors available in a hospital through a WhatsApp chat. That is a AI, conversational AI chatbot is powering that one. And if they wanted to make a booking online, they can go to the website. We have a companion app. They can download the app or make a call to the hospital. That's the call center is there. If they come to the hospital, they can do it at the counter or in a kiosk. So technology made it possible to provide the same service, unified services across multiple channels. Okay, there is a cost involved in setting up all those things, but if you work out the unit cost, I'm talking more from an operational angle. So my unit cost has come down because it's when I'm employing a person to provide these services. Now I'm pushing these services. That's from a patient engagement angle. The cost has come down because it's leveraging technology. My operational cost is the number of people involved in carrying out all these transactions. I could cut down on the manpower, whereas some of the using self-services, the patients themselves. But there is a limitation to that one. Only the educated ones, they are able to use these services doing self-serve, but still the senior citizens, they need assistance in terms of using all the gadgets or technology that is there. But it is providing a better experience. So during the COVID period, people were afraid to handle cash. So it's providing a UPI or a digital payment mode. They are able to transact right from making an appointment, coming to hospital, doing a registration. That's also using a mobile without coming to the counter, then check in, then do a payment. Everything is online now. And even after the investigation, okay, they do a consult in the hospital OP room. After that one, the lab investigation results can be downloaded. So we created a digital front door for interacting, transacting with the users. That gives a better experience for them. Using the tele consultation itself, so if you look at, as Dr. Venkat said, it's a hybrid model is evolving. Maybe most of the doctors and the patients feel comfortable. For the first consultation, they would like to have a face-to-face because the patient need to be thoroughly examined. Apart from the information that they provide over a phone, need to be thoroughly examined. But subsequent follow-up or review can be, depending upon the case, it can be over phone. Similarly, for a surgery, a pre-surgery evaluation can be, to some extent, it can be done, or post-procedure, post-surgery follow-up can be done. So even in that area also, we have identified use cases. We implemented systems using conversational AI. During the COVID period, patients who were like categorized as A category, B category, that's severe in Kerala context I'm talking about. Those with the severe symptoms, they were admitted in the hospitals because of the shortage of hospital beds. Others were provided care from home. We had a challenge scaling up. So we use the technology platform. So the patients are enrolled in that one through WhatsApp as a media. So we reached out to them after enrollment. Every like a scheduled time, like frequent, we were interacting with them, pushing them all the required contents, giving them the assurance a hospital or a medical team is behind checking, and also checking on them the vitals and other progresses, the medication reminders, all those things were all the transactions, the reminders, the conversation. 80% of the things were done by the board. 20% cases, and a medical practitioner need to intervene and provide help there. So that way we were able to scale up also using this digital technology. So that is our cases. So in those cases also the cost was less. So we were able to reduce the cost. What I would see is the objective of using technology is to reduce the cost. That is the make it affordable, more affordable for the patients. Maybe in the initial, when from an ROI perspective, initially you may have a bigger investment. But from a longer run, it should produce, from a unit cost perspective, it should reduce. And also it should increase the reach, the accessibility. Because it's when we talk about Bharat, majority of our citizens are in rural folks. So how do we reach out to them? So by leveraging technology and also the number of medical professionals or the resources available to us. For example, take a radiology. For example, if you have to engage a radiologist to do all the image reading and interpretations, if you can use algorithms and things to sort it out, prioritize, and then so you'll be increasing your capacity with the same human resources. You can increase your capacity. So it's in manifold. Operationally, this is going to help us and going to help us reduce the cost in the long run. That's my perspective.
Thank you. Thank you. And you have mentioned two very critical points, that how more technology adoption can lead to one, increasing the accessibility, expanding the reach, and more important, reducing the expenses also. I'll come to you, Bhoopendra, next. Bhoopendra, if you can switch your camera on. Yeah, my question is, we are talking about the new gen technologies, be it analytics, or someone talked about even the RPA being used. Then increasingly, we are seeing IoT adoption also. Now, my question is, one, hospitals do have certain legacy IT systems. They do have certain systems belonging to medical technology, not necessarily IT, and they have certain, when you are talking IoT adoption, even the OT related technology. So there are a lot of these technologies in silos. Now, when we are talking about these smart hospitals, how would all these technologies, be it IT, OT, or medical technologies, how do you integrate all of them so that smart hospital of the future emerges? Bhupendra.
Yeah. Good afternoon, everyone, and thank you very much for the team APAC to organize such wonderful event to transform the information to across community. Now I am coming to the question. Yes, definitely, it's a very good question, and then some portion of this question already addressed by Dr. Venkat. Thing is, the in hospital, every hospital using the HIS. We called HIS as a backbone of the complete clinical care, as well as the financial part, and this discharge summary report, appointment, everything. So that backbones applications should be scalable and easy to integrate, and accept the new technology which are available in the market. Like, you can't replace the HIS, but it should be a capable to handle the upcoming application or new technologies in such a manner where, with the less effort and less commercial involved, we can integrate with the new technology. One thing. Coming to second portion, the OT integration and this medical equipment data. Yes, that is the challenge, but now it's becoming easy as the new equipments are coming and they are capable to transfer the data by themselves with the help somewhere IoT or HL7 protocol. So that data and the CIO and IT head have to look on that, how easily they can transfer the data to backbone software, means HIS. That is a single this data container in each hospital. So in that segment, now all the equipment coming with the capability to transfer data easily to HIS. If data is available in one bank, so you can easily pull and display to patient, display to internal department like marketing, like clinical care, research purpose, and utilize that for the better clinical care in the society. Like, marketing can run the campaign based on any criteria, like diabetic and all. They can inform. They are not going to force the patient like they have to come to hospital, their hospital only. But yes, they are providing the information. You done your test the 6 months before. Now it's due. So if you want to, you can give your repeat test to know your health. So in that manner, that technology can help to provide the data real time, or whenever, wherever it is required, to the respective people. Similarly, clinical care research. Doctor are doing same type of surgery, like ortho doctor is doing same type of surgery since 10 year, 20 year. But in 10 year ago or 15 year ago, it is difficult to take that data and analyze what has happened for that surgery, and where we done best, where we done some lack of the procedure or something. So that way they can, now it is easily available and they can do the utilize that data for research purpose as well. So data availability is the biggest challenge. but now it's slowly it's coming in better manner, and all the hospital trying to bring the best HIS, which can help to integrate different kind of technology so that they can bring like IoT, AI, ML, RPA, and then big data analysis. So my thought on this, technology will help to provide a affordable clinical care in smart hospitals. That's it.
Thank you. Affordable clinical care in smart hospitals. While obviously the affordability part, all the panelists till now have spoken about, and we would come to it to speak about a little more detail later. The clinical part of it is, and I come to you, Dr. Radhakrishna. My question is, when we are talking about the entire healthcare ecosystem, one obviously the technology people who are looking at deploying technology to make healthcare more affordable and expand the reach. But the ecosystem, there are other very critical players in the ecosystem, the caregivers themselves, the doctors, the nurses, other healthcare professionals. So, when we are talking about smart hospitals and integrating various technologies there, unless all these stakeholders in the overall ecosystem, the doctors, the other nurses, the healthcare professionals, and other caregivers are not in sync, this smooth integration would never be possible. So, what do you think are the bottlenecks in this smoother integration, and how are things changing for a future smart hospital? Dr. Radhakrishnan.
Yeah, thank you. Good afternoon, everybody. It's a privilege to be part of this discussion. And I got an excellent question. Whatever new technologies are coming, the implementation is something which finally gives you the result. And when it comes to healthcare, probably even now there's no scope for any kind of technological information given during the medical schooling or even the post graduation. Now, probably recently they have introduced some computer science in the course. Otherwise, most of the doctors have no exposure to any structured technological things at all. And when it comes to implementation, I think the major bottleneck would be the lack of understanding from the clinical side, so that you don't have easy ways to implement any new technology. HIS, when it is introduced, the first basic block what we used to have was doctors only to accept it. Then they realized the easiness, then the adaptability came in a little later. But going into proper EMRs, even now, I think 80% of the small and mid-sized hospitals don't have a proper EMR. So whenever you're talking about adaptation of technology, I personally look at it two different ways. One is clinical side, the second is the operational side, administrative side. The adaptability of technology from the operational side is relatively easier because there are people who are from the technology background. There are people who have exposure to different things, but when it comes to clinical side, I think there's a big gap. Definitely, you need a bridging of technology people between and the clinical teams, which is, I think, is not an easy task. And whatever technology we are talking about, I mean, if you are looking at RPA, we are looking at AI implementation and all that. Majority of them are, I think, very, very nascent. They're not, can't be called as a very good advanced level of technologies used in most of the hospitals. So the bottleneck first is the understanding of the technology and the adaptability of the technology from the clinical side. That's my view, because that's what we faced also during pandemic, when the teleconsultations started, and it was literally forced upon the clinical side to use the teleconsultations. That's when I think people started taking it. They started working on it, and then the adoption of teleconsultations came in because of a forced situation. But now, looking after 2 years of this pandemic, the number of teleconsultations have, I think, dropped down significantly. I think it's gone down by 80% again. People are again back to the regular consultations and all that. So, technology adoption can happen if there is the technology is quite easy to adopt, and the benefits are very visible, and patients are ready to accept that technology from a clinical point of view. If patient wants to see the doctor personally, it's very difficult for us to push the teleconsultation, and the habit of seeing a doctor is so high in Indian context. We will not be able to actually diagnose the conditions majority of the time, because the interpretation of the things, the way they express their symptoms are not uniform, because the background of the patients, their education, their understanding of the things, their expressing the symptoms are quite different. And until unless we have a personal interaction, it was quite difficult. As Saji was saying, it's easier for the follow-up, but not for the first consultation, majority of the times. So, and teleconsultation is only a very basic thing when it comes to the new technologies. The adaptability for operational side, I think, is a little easier. What we saw, the adaptability from pharmacy, from the laboratory and diagnostic side, is much easier than compared to clinical side.
Okay. Thank you. So, again, a very critical part you touched about, that when we are talking about technology adoption, there is a mismatch between the clinical side and technology side, and we can never expect a very smooth migration to what we are calling smart hospital unless there is more, I may say, synchronization between the clinical and operational side. And clinical, there is a challenge, as you rightly mentioned, post pandemic, as the teleconsultation numbers are going down, showing that there is still, if I may use the word, resistance or not comfort, maybe for all patients to move to a highly digital mode. We have one round of questions with all the panelists. I'll come back to Dr. Venkat. Another important aspect from a hospital perspective when we are talking about technology is the use of artificial intelligence or analytics. Now, the problem here is one, you can only effectively use analytics and do some sort of predictive analytics, which can help in maybe early prognosis or something about certain diseases, only when there is sufficient amount of data. And the challenge with sufficient amount of data, especially in the healthcare fraternities, there is a issue of data privacy. So the data privacy issue sort of poses a challenge as to the nature and quality of the data which is collected. And also we touched about the telemedicine. Telemedicine, apart from all this, has a medical legal aspect to that also. So keeping in light of these situations, what are the challenges when a smart hospital which needs to analyze more data, how do they mitigate the challenges of data privacy issues, as well as the medical legal aspects of some of the digitization. Over to you, Dr. Venkat.
Yeah, it's a good question. Again, requires a lot of time to discuss, and 5 minutes or 10 minutes is really too small a time because it's a vast topic. But if you want me to say a few words about this, you're quite correct. The quality of data is very important, not just the quantity. And in my day-to-day practice, I almost every day I use AI in my own practice, and AI in radiology is now well established. And as an example, just yesterday, I use a company from Israel to analyze some of the images, and it did not pick up a small subarachnoid hemorrhage in a very young patient, and it had to be picked up by a human being, and sent to the neurosurgery. So just gives you an example that you know nothing is 100%, and the quality of data used at machine learning is very, very important, because unless you get those right, it's impossible to really depend too much on the AI or automation in that sense, because patient safety is a top priority still. We all hope that the new technology will help us be more productive and patients are more benefited, etc. But this is an example where you still have to have a human touch, human understanding, because clinical medicine is very much logic based, reasoning based, and experience based. So you cannot replace the last part, which is the experience of the doctor who is treating the patient, because they will really know what each and individual case is, and each and every individual case is different in clinical medicine. um, so that is the data part. What was the other question that you asked, Mr. Rajneesh?
The medical legal aspect when we're
Yeah,
especially talking about telemedicine. Yeah.
correct. Yeah. So again, this raises huge amounts of questions regarding where we are when we use all sorts of technology. And as an example, in my own field of radiology, whether we use artificial intelligence or machine learning or not, every case has to be signed off by a human, a radiologist. So that is still there. So we can't legally or even clinically rely completely on the uh, machine learning algorithms as of now, but that may change in the next few decades, I feel. And Supreme Court has, in early COVID times, has come out with some guidelines regarding use of telemedicine and its legality. So they are now conscious of that, and they are making amendments to the situations as we speak. But I frankly believe that there may be another amendment, because that judgment or that guidelines was during the COVID times, which is the most unusual in one's lifetime. Hopefully not. We may not need another lockdown in the near future or in our lifetime. But at those times, the legality was a little bit more flexible because there was no other options, and it was humanity saving each other's lives. And so those were exceptional circumstances. But when we're talking about going back to normal circumstances, there has to be another set of specific guidelines regarding these. And they are coming out. They need to be polished. But we all, as clinicians, also have to be aware of the limitations. For example, telemedicine, you can only see uh, a few sets of cases. Diabetes is one example where you can really see, because all you need is the parameters when they go to blood sugar measurements and HbA1c. But unlike gynecology, where a patient comes with bleed, you have to have a physical examination done. Otherwise, you may miss major findings and delay patient's treatment. So it's all up to the clinical part, I think. So patient care is again the center of whatever we do and whatever technology we have. Legally speaking, we all have to be in the right side of the law. But government will come up, I hope, with some newer laws regarding use of AI, use of RAPs, use of telemedicine, in the non-COVID conditions, in the normal periods also, so that there is a balance between increased access to all the uh, treatments or the latest treatments that we can provide to the patient, and also at the same time, you know, improving patient's care and patient safety in the long run. Thank you.
Thank you. Thank you, Dr. Venkat. Saji, I'll come to you next. Again, I will put to you a question uh, which is related to the operational side. We are talking so much about these the new gen technologies or other technologies, integrating it. Another operational challenge is this requires technology teams or people with relevant technology skill sets to implement. And for a hospital or a healthcare institution, definitely that is not their core area of expertise in terms of having technology teams. That means increasingly working with third party service providers, outsourcing to third party service providers, technology solution providers. Now, increasingly, many of the applications are moving towards cloud also. For a hospital, what are the operational challenges in working in a synchronized mode with these third party solution providers, and especially considering that hospitals still have certain legacy systems? And what is the road forward for hospitals there, Saji?
As you rightly said, there are a lot of challenges, especially on the resource front and also on the adoption. And then when we look at the economic feasibility, all of these points definitely need to be taken into consideration, and given we need to deliberate on it. In our case, luckily, I'm having two clinicians, those who have a clinical background. One is after his MBBS and MD decided to be on the technical path. So he loved his entire practice, and he has developed a lot of applications leveraging technology because he is quite passionate about technology. Another neurologist, he is also part-time into. He developed a application that is in the India trained status, which has like a 10 million downloads, and he makes more money from his app than his practice. So there are few doctors who got involved with us in developing applications. We leverage, because we whatever innovations we have done, it's all low cost. We looked at the various technical features available through cloud or other technologies. We implemented in house, and that innovations also, I would say, it is an incremental innovations, because it's one of the challenges when we work with a third party service provider or an integrator. We need to tell them upfront, okay, what we need, and we need to get into a contract. We need to have a specific the requirements being properly specified. Otherwise, everything will be a change request, and that will take more time and then more cost in implementation. So those are the typical challenges. In this case, we had an HAS, so we kept that as the core and in the backend. On top of that one, so we created various APIs and exposed whatever functionalities through the API. Then we leverage created various peripheral systems both on the cloud and browser technology or on the mobile app. And there the features comes. So being coming from a clinical background, these doctors were able to create excellent applications. One for use by the clinicians on the move. They get the list of patients. They can prepare the discharge summary. They get to communicate with the nurses, given written orders. It's rather than on a verbal order. So a lot of this operational. I'm not going into the details of the clinical decision support or in the part of how we leverage technology for diagnostic. At least on the operational part, we were. And the pain points by a doctor, I mean, as rightly highlighted, the doctors understand their pain points better than a technician or somebody coming from a technical background. So they, by leveraging for the COVID in the peak, we had around 250 patients admitted. We had a team of critical care consultants and people from pulmonology, medicine together. The patients who are admitted in the ICUs and all, we developed our own technology in house. in terms of capturing vitals from the patient monitor. Because other option is that we go for a ICU setup, which is pretty costly. So we just use the mobile phones, focus on the monitor, we capture all the vital signs, and then use the NLP capabilities on the mobile itself. So the resident doctors, the juniors who are inside the ICU, the nurses, they were able to capture all the record information. So those informations were made available to the senior doctors. They were guiding them from being, because of the age and all, they were a bit skeptical going inside the ICUs. So this is how we manage, because it's a team of doctors who do. Even the telemedicine, the video consultation part, one of the doctor who very passionate about, he created a peer-to-peer tele platform, which is a serverless, and it's done by, and he got an award also in a hackathon from Google for developing that. It is the doctors, and also in our emergency room management, the emergency room, the emergency department head and the neurologist came, they created an app. Now we did a piloting and it is working well here. So we are going to make even as a commercial product also for others to use it. So it's involvement from the clinicians is very, and understanding their requirements, involvement from them, and doing it an incremental, because it's when you approach a clinician, the hospital team, unless in the, I'm coming from a financial services sector, more people are IT savvy, the technology adoption in finance is better. So we will be able to approach the software development and other stuff in a more structured fashion, following the principles of software engineering. So we are able to do those things. But when it comes to clinical context, it is slightly different. We need to work closely with people and we need to take an incremental approach. So that's the thing. And we leverage largely in Kerala, we have a Kerala startup machine and startup ecosystem. Some of these we leverage them for that one. We mentored, we created a launch pad for them. So it become eventually okay. So some of the IP, so we co-own, and the total cost of ownership for these features or products that we have, for us it's less because of our involvement with the startups and mentoring them, creating them an opportunity to. So the products which they have developed given to us, it's free of cost. So we need to maintain together with them. That is there. But so this is how we leverage. So one is leveraging the startup ecosystem, which is a low cost option for. But you need to closely monitor them, ensure the quality is there, because it's unless you take use of those big boys and then people who are doing enterprise grade application development, the cost is very high. But for the startups, the cost, they have idea, but you need to guide them, mentor them to produce a good quality software applications. Then working closely with the clinicians, understanding their pain points, addressing that in an incremental, because until you show the product to them, the application to them, they will not be able to give much inputs to you. Once they start using, they will the inputs if they like it. As highlighted, the usability comes very great. If you create a lot of forms and other things, ask them to fill it up, people may not like it. So we, wherever possible, it's the discharge summary, for example, without cost. Gboard, there is a voice to text conversion is there. So we just leverage. There is a privacy concern. So we did what we did is without UHID or anything embedded as part of any other communication. It's a plain English text goes between the mobile phone and the desktop, where the secretary is copy paste and then they use that one to do it. So that is how we manage it. It's a different approach from a traditional style we do. So it's a mix of expertise we have, but may not be the resources. Resources part we leverage startup ecosystem and other low cost options. But we have the expertise and the willingness to participate, and we were more being bit tech savvy. But addressing Dr. Radha's concern, so now even in India, IIT Kharagpur started a school of medical sciences and technology. So we need this kind of a approach, because it's people from multidisciplinary approach. Like in the West now, we can see most of the research projects or advancements happen because of a multidisciplinary approach. Technologists and the clinicians with the right knowledge come together, creates even common, the layman or the legal side people are also involved. When you apply for a project or funding, even they involve people from various disciplines to work a multidisciplinary project, which see a better outcome in terms of researches also. So we need to work on a multidisciplinary approach in developing newer products in terms of technology adoption also. The technology is there. If you look at the cognitive capabilities of computing, it's maybe I would say 90% in parity with the human capabilities. But how do we apply it rightly in our clinical context, in our operational context, in the hospital context? So the computers are, I mean, the machine is getting that kind of a cognitive capability. It is gaining that parity also.
Okay, thank you. The interesting part was that incremental approach that you also talked about. Bhupendra, I'll come to you next. My question is again these new gen technologies we heard about. Heard about the apps. A lot of these mobile apps regarding need not always be telemedicine, but certain other healthcare related apps are there. So that moment these mobile apps are there, another concern is cybersecurity. How do you sort of mitigate the cybersecurity challenges? So one, how are newer technologies like blockchain being adopted to address these cybersecurity challenges? That is one part of the question, and another part I would like to see in any healthcare setup today. They are very intimately connected with the insurance sector. We all know. Now, insurance, if we look in terms of technology adoption, is very savvy, and they are further ahead in that adoption curve than the healthcare sector. Now, this not being in sync in terms of adoption, how does that create a problem for the normal patients in terms of when the claims processing is concerned? How do you would you advise that gap is narrowed down in technology adoption between insurance and um, health?
Yeah. Yes, it's a biggest challenge, and more than 30, I can say this insurance player are available in India, and there is no single platform to integrate with the hospitals. So every TPA or insurer having their own applications, and hospital having their own applications, and the old HIS doesn't have that even functionality to integrate with the upcoming new solutions. So that is the biggest challenge to overcome of this challenge. Government or some neutral this player come forward and develop one application where hospital can push the required data from the patient side, which is essentially required for the TPA approval, and then TPA work accordingly with the same application and push back to the hospital HIS. So some neutral player is required instead of a single hospital or single TPA, or government can come forward to bring all these challenges, to bring all these functionality in one application. So one part of it, as of now, it is really difficult. Few players are available in the market who provides the like a single insurer platform. So we also taken with the one player, and then HIS pushing the data to that player, and player sending to the approval things to our hospital. So that way, but this is not the holistic solution. It's with the one TPA TPA provider or insurer application. So in that segment, some neutral player or government come forward, bring the one application, and which help to all the hospitals and all the TPA and insurer. Second is cyber security. Yes, it is the biggest challenge. So whatever things are available in the technology field, we are adopting, but still some loops or gaps are there always in terms of technology or even manual processes also. So to overcome that, we as an organization, we plan like in every second year we'll do the VAPT test wherever the application are public facing application. So in that we are bringing mobile app yes, is about to launch in this month only. So if before launching, we done one round of VAPT test to ensure at least 99% things will not going to spread unnecessarily, or people cannot enter without the proper access. So we are trying to mitigate or minimize the risk with the help of VAPT and experts opinion in it. But cyber security law also should come from the government side strongly. Currently it is available, but not it's in a specific format. So we will request to use your forum to government. We should come back with the effective security, cyber security law. So people will afraid to steal or to manipulate the information through the this technology platform. So this is my opinion on it.
Sure. Thank you. Dr. Radhakrishna, the last question of this round. My question is now usage of technology in one in the surgery technologies like say RPA or robotics usage in surgery, or in some cases very critical diagnosis, things like what I can say, breast cancer, ovarian cancer, those kind of things where specific technologies or maybe even an RPA kind of or IoT kind of technology can be used, or in surgeries where RPA can be used. Uh, while technologically that might be viable, the biggest challenge there is whether it will be economically feasible for a vast section of the patients to avail of these technologies. So, what are the challenges there, and how are hospitals looking to overcome that financial challenge?
Yeah, I mean, before I comment on your question, I just want to put a couple of things to add to what Saji was saying and what other speakers are saying. I think National Digital Health Mission probably will give us some platform, a common platform where there's some kind of interoperability, some kind of uniformity to the collection of data, and probably some work is getting done on that platform where I think overall there'll be a uniform kind of guidelines from the central government. I think it's doing good right now. They have their strategy plan and all that, which is available on the net, shows a good plan where the digitization of data and the exiting from the this data silos from different hospitals probably will happen in the next few years. That's one thing where I think the push for this quality data and interoperability and the patient's engagement through that machine, I think will give us a great platform for us to implement a few of these things. And as I expressed in my first opinion also, there's a lot of gap between the understanding of the technology from the clinicians, and it's getting addressed now. See, I'm a practicing orthopedic surgeon, very passionate about technology. But the thing is, when you want to get trained in certain things, you don't get too many courses to get trained in technology right now. That is because there is a gap in understanding the need of such people who requires to get exposed to on both sides. So if you are a doctor and as Saji was saying, they have a couple of doctors, one who is completely passionate about technology and gone into the technology. Those are the people who will definitely make a huge difference. And I think we need a force of such people for taking this to the next level. And the government should look at, and even the premier institutes should look at integrating these two, getting some technology people who are definitely passionate about knowing about clinical science a bit, and the other way around, which is probably relatively easier because getting those doctors who are interested to have technology training to make the adaptability much easier. And when it comes to surgeries and all that, well, I don't think we are there yet. There's a long way to go. The robotics, what we are talking about, I think it's there still in we use robot for operating it, but that is it's completely in silos. There's nothing beyond it. It's particular patient, particular surgery only, not anyway beyond it yet. As far as I know, probably there are few centers where they started using those data points while operating and all that into integrating into a decision making algorithms, but I think it's not happening yet.
Yeah,
That's my opinion.
sure. Thanks. We are come to the last round, and briefly to each panelist, just 1 minute each. I will ask when we are talking about smart hospital for the next, if I may say, 4 or 5 quarters, next 1 to 1.5 years, from your hospital perspective, what are the plans or initiatives or your key focus areas vis-a-vis these smart hospitals? I'll start with you, Dr. Venkat.
Yes, thank you. So my focus, as I've been saying right from the beginning, has always been on patient care and maintaining the reasonable cost that we provide to the patients. Uh, in our hospital, we provide a lot of services to abroad, to the UK and European hospitals where we do teleradiology. And even in that case, we started to use AI, which has become mainstream now since the last 2 years. Again, the process is not to increase the cost to the patient, but to improve the productivity, to um, get faster reports out of the machines that we use, faster and also safer is probably a more important word that we use. So I think technology is here to stay. It's good that we are all embracing technology, but there is always a caution. So not every technology may be appropriate in one location or one situation. So we all just have to be aware of that and keep patient as our center or our priority in whatever we do. Thank you.
Thank you, Dr. Venkat. Saji, 1 minute. What are going to be your key focus areas?
It's as Dr. Venkat highlighted, it's a human-centric approach is required because we cannot replace the human touch with technology. So it is a human-centric approach. In adopting technology, our focus is on providing better experiences and better outcome, reducing the cost. So improving productivity, so better experience for the staff members. So what we have done is, okay, we are piloting wearables for measuring the vitals from the ward, which work out to be cheaper because rather than a nurse running up and down to on a periodic basis to collect these many of these technology. So identifying and implementing appropriate technology, not going after a hype, saying okay, somebody having a robotic surgery unit, okay, that is not affordable, economically viable in our context. Rather, identify those things which are appropriate in our context, implement them, show the benefits to the various stakeholders, and then take it forward from there. So that is how we are approaching it.
Thank you. Bhoopendra, your 1 minute.
Yeah. Yes, we have planned and bringing the patient engagement tools like mobile app, web chat, WhatsApp chat, Facebook, Instagram, all kind of chats. So different kind of people available and as per their use. So if they are familiar with the Facebook, so they can get in touch through Facebook to hospital. So these chat will help in that, and this. Step down ICU we are planning with the help of home care and smart IPD rooms. So all smart IPD rooms mean if nurse going to patient room, she has not to come back to the reception and all. She will be able to do everything within a patient room, and patient also can see the informative videos and the request through the voice over command. So that way we are planning. So our target is next 4 to 5 quarter, we will bring all these things. That's it.
Thank you. And Dr. Radhakrishna, what are the key initiatives that you are planning?
Yeah, I mean, actually, we are looking at full-fledged EMR. We don't have EMR yet. That's our primary focus right now. We are still in the HIS things, but looking at EMR as our primary focus for the next probably a couple of years. And in operational side, we are going into this pharmacy. We are definitely looking at a much more advanced thing than the clinical side. The only those two are the focus areas right now. We are not looking at app and all that yet. We tried it during our COVID time, but we were not really comfortable with what the product came out. So we are looking at our first data management. So we wanted to have a quality data first, then EMRs are our first focus now.
Thank you. Thanks to all the panelists, and as we move out in a post-COVID world and a sort of a hybrid model which is likely to emerge, and we got a brief glimpse of what the smart hospitals of the future would look like. Before we sign off, from on behalf of APAC News Network, we would like to hand over the digital certificate of appreciation to all the panelists. The first certificate of appreciation presented to Dr. Venkat Ramana Sudigali, Director and CEO, Excel Hospital. Congratulations, Dr. Venkat.
Thank you very much.
Yeah, the certificate of appreciation presented to Saji Mathew, CEO of Baby Memorial Hospital. Congratulations, Saji.
Thank you so much.
The certificate of appreciation presented to Bhoopendra Solanki, Head IT at Sakra World Hospital. Congratulations, Bhoopendra.
Yeah, thank you, Mr. Rajneesh and Team APAC. Thank you.
Welcome. The certificate of appreciation presented to Dr. Radha Krishna Rao Sagi, Chief Consultant Orthopaedic Surgeon and Head of ORTHOHEXAGON at Prathima Hospitals. Congratulations, Dr. Radha Krishna.
Thank you. Thank you.
So with this, we come to an end. Greatly appreciate the time you have taken out for this insightful discussion, and I'm sure certain best practices would emerge out of these, and all the audience who witnessed the discussion, that would be beneficial for them to apply at their institutions back. Thank you all.
Thank you.
Thank you.